Thank you, Charles, for the introduction. Today I'm going to talk you through some cases of multi-drug resistant gonorrhea infection we've seen in the UK, which failed empirical therapy, and briefly describe resistance-guided therapy and the reasons for including it in the UK guidelines. I have no financial disclosures. We all know that gonorrhea resistance is a global health threat and a high priority for the WHO. In the vast majority of cases, gonorrhea infection is treated empirically. That means without the results of antibiotic susceptibility testing. An empirical therapy is chosen as the antibiotic most likely to successfully cure more than 95% of infections. And this is based on surveillance data. Usually it's been given as a single dose of monotherapy, but over the last few decades, successive classes of antibiotics have been lost as resistance has developed. And you can see on this timeline how quickly resistance has developed as each antibiotic has been introduced. Worryingly, ceftriaxone is our last antibiotic. You can see from this map that ceftriaxone resistance is already quite prevalent in some regions, particularly in the Asia-Pacific region. In an attempt to delay the emergence of ceftriaxone resistance, most countries switched to dual therapy with IM ceftriaxone plus oral azithromycin around 10 years ago. In 2015, we reported the first case of dual therapy failure, which was a case of pharyngeal gonorrhea with ceftriaxone resistance and low-level azithromycin resistance, which had been acquired in Japan. And I'll now take you through some more recent cases of treatment failure. So in 2018, a heterosexual male in his 50s presented to a sexual health clinic with 4 days of urethral discharge and dysuria. He had a female partner from the UK who he'd been with for 6 months, but had also had sex with a Thai female in Thailand a few weeks earlier. Based on a positive gram stain, he was treated empirically for gonorrhea with a gram of ceftriaxone, which was the local clinic policy as they'd never adopted dual therapy. The isolate that had been cultured from the urethral swab was resistant to ceftriaxone with an MIC of 0.5 milligrams per litre, and also had high-level resistance to azithromycin with an MIC of greater than 256 milligrams per litre. This is the first time that this phenotype had ever been seen. You can see it's also resistant to everything else apart from spectinomycin with an MIC of 8, and had fairly low MICs to both gentamicin and ertapenem, although no breakpoints are available. So based on these culture results, the patient was recalled for review. He was asymptomatic, but repeat tests were taken. He denied any sexual contact since treatment, and out of an abundance of caution, it was decided to give him some spectinomycin. When he returned 3 weeks later for further follow-up, he had remained asymptomatic. His urine nat and urethral culture that had been taken at the previous visit were negative, implying that ceftriaxone had successfully treated his urethral infection. He had not had any sex since treatment, and his UK partner was negative in any case. However, we advised that they should take pharyngeal swabs just to make sure that there was no remaining infection given the antibiogram, and unfortunately this was positive, showing that both ceftriaxone and spectinomycin had failed to clear the pharyngeal infection. Pharyngeal gonorrhea is a concern as it is asymptomatic, may contribute towards onward transmission and development of AMR. In the UK guideline, we recommend that pharyngeal sampling should be routine in all MSM and considered in women who are sexual contacts and by risk assessment. It's harder to treat than genital infection. We know that antimicrobials must reach the site of infection in unbound concentrations that are effective, but we lack pharyngeal PK/PD data to guide treatment recommendations. So we decided to treat him with 3 days of IV Ertapenem, 1 gram. This was based on the fact we know Ertapenem has good in vitro microbiological activity against gonorrhea, and the MICs to Ertapenem tend to parallel those of ceftriaxone, and isolates with high ceftriaxone MICs tend to have lower Ertapenem MICs, as we saw in this case. At the time, there was no clinical data to guide treatment, and so a pragmatic decision was taken on a dosing regimen. Whole genome sequencing showed that the urethral and pharyngeal isolates were identical to each other, but different from any previous ceftriaxone-resistant gonorrhea. However, shortly afterwards, the Australians reported 2 isolates with the same antibiotic susceptibility pattern as our UK isolate, and one of these Australian cases had been acquired in the Asia-Pacific region. On whole genome sequencing, they were identical to each other and only one SNP different to the UK case, suggesting that there's likely to be many more cases undetected in the Asia-Pacific region. We then had some further cases of ceftriaxone-resistant gonorrhoea later that year. The first was of a female who presented to a sexual health clinic with dysuria. She'd had more than one partner in Ibiza. They were all UK men and not contactable. She had a positive NAT and so was treated empirically with ceftriaxone 500 mg plus a gram of azithromycin and had a negative test of cure 3 weeks later. However, the culture that had been taken at the first visit showed ceftriaxone-resistant gonorrhoea with an MIC of 1 mg per litre and intermediate susceptibility to azithromycin with an MIC of 0.5. But fortunately, the empirical therapy had successfully cleared her infection. Shortly afterwards, another lady attended a different sexual health clinic for an asymptomatic screen, 2 weeks after unprotected vaginal, oral and anal sex with a UK resident man who had been in Ibiza very recently. She had positive vaginal and rectal NATs and a negative throat NAT and was culture negative at all sites. Based on the results of these NATs, she was recalled and treated with a gram of ceftriaxone, and at this visit said that she had developed some rectal symptoms. Initially, however, she responded but relapsed and then went to visit her GP, who took a culture and found, again, ceftriaxone-resistant gonorrhoea with the same antibiogram as the previous lady. But as she still had symptoms, she was referred to the clinic where she was found to be both culture and NAT positive, both the rectum and the cervix, but not the throat. So based on this, she was treated with second-line therapy with gentamicin 240 mg plus 2 grams of azithromycin. However, a week later, she had no improvement in her symptoms. She was therefore treated again with Ertapenem, and her symptoms fortunately resolved, and she had a negative test of cure 2 weeks later. These two cases were identical to each other on whole genome sequencing, and were part of the FC428 clone, which has been detected globally, often associated with travel to the Asia-Pacific region. Isolates from this clone are ceftriaxone resistant and have varying levels of azithromycin MICs from susceptible to low-level resistant. Clearly, ceftriaxone resistance in gonorrhoea is emerging and new treatments are needed. And it's great that we have 2 agents in phase 3 trials. However, while we wait for these to be available, what other strategies are available? Gonococcal vaccines are in early development stages, but the MenB vaccine is being investigated for its effectiveness against gonorrhoea. Older antibiotics may also be useful in select cases, such as Ertapenem, which I've illustrated. Resistance-guided therapy is another option which could be utilised before any of our other options become available. With this in mind, we decided to be proactive in the updated UK management guidelines. We switched empirical therapy from dual treatment to ceftriaxone monotherapy at the higher dose of 1 gram. I'm not going to discuss the pros and cons of this approach, but I hope you will join the live debate on this topic later today. We also introduced the option of using ciprofloxacin when the infection was known to be susceptible. It's important to try and understand that empirical therapy is not the best treatment, it's just the one most likely to work when you're treating blind. And it's the universal use of the broadest treatment available. It can promote resistance through selective pressure, and so by using alternative antibiotics, you may reduce this selective pressure and possibly delay the emergence of ceftriaxone resistance. For individualised treatment, you need to know the antibiotic susceptibility in near real time to be able to influence prescribing. The problem with culture is that it is slow and also not done in many countries. Using molecular methods, you can identify drug resistance markers, although they won't detect novel mechanisms, and so culture for surveillance is still required. NATs can reliably detect the GIRA mutations which are associated with fluoroquinolone resistance, and historically ciprofloxacin has been a highly effective treatment. NATs are less reliable for predicting cephalosporin and azithromycin resistance, as multiple mechanisms are involved and not all are well defined. For a great talk describing these in more detail, please look at Dr. Alan Blitz's talk in the Resistance Guided Therapy Symposium. So does it work? Well, there are several studies showing that resistance-guided therapy using ciprofloxacin will successfully treat infection and can also reduce the use of ceftriaxone in the clinical service. Whether this has any impact on delaying the emergence and spread of ceftriaxone resistance remains to be seen. Thank the GRASP team for help with these slides, and now I'm going to hand over to Dr. Andrew Winter and the lessons learned from implementing resistance testing into a laboratory and clinical setting. Thank you.